Does it look like the plugins working? Hello, I'm Dr. Roger Elmer, Advanced Neurospinal Solutions. I'm a structural correction specialist and a board-certified chiropractic neurologist and specializing in functional neurology. And I've been asked to comment on Alzheimer's. And so what I'd like to do is expand it just a little bit to talk about the disorders, the degenerative disorders of the brain, which include three major disorders. We know about Alzheimer's, and we call it frontotemporal demise, which we call dementia, but also Parkinson's. Parkinson's we don't normally think of as a brain degenerative disorder, but it is. It's a brain degenerative disorder that has a movement disorder inside of it. And so we're going to talk about all three, where they come from, what can be done relating to them. But we distinguish them by their presentation. Usually the situation happens with a severe head-forward posture. That creates a decrease in what we call the adult brain, or the posterior compartment. As we're babies, we tend to be flexion beings. And as we become adults, we develop the neurology that drives the muscular system that holds us upright. And as we begin to lose that, we begin to go back into that baby brain, baby system. And so we lose the adult brain. And that's the degenerative process. But if we work to overcome that, then we can buck that loss. And that's part of the strategy in solving these problems and making it so that people can have better activity, better function, better memory, and better life all the way to the end. But if we look at the brain, this is, oh goodness, they won't be able to see this probably. Can you see that?
Vaguely. I can get one from Melissa's office.
Okay. This is the left side of the brain. Thank you. This is the left side of the brain. This is the frontal lobe up front here. This is the parietal lobe, occipital lobe, temporal lobe, frontal lobe. Okay, and when we look at that, we're like I say, we're looking at the left side of the brain. The part that relates to movement is in the front. The part that is sensory is in the back. So 80% of your brain and nervous system is about receiving information. Only 20% is coming back. And the stuff that's on the outside here towards us relates to movement that is not emotional. My wife says, smile for the camera, and I do this. She says, no, a real smile. And so I give her a real smile. This is a limbic smile. Some of the same pathways were used, but they was hijacked by a part of my brain that's emotional, and you can tell the difference between the two. In fact, if you were to look at old pictures of yourself, you'll be able to see, was that a real smile or was it a baloney smile? So, but this part of it is the non-emotional movement system. If we were to take both hemispheres and pull them apart, on the inside, that's where the emotional part of the movement system is, or we call it the limbic brain. So we'll use this to differentiate between the three degenerative brain disorders. The first one we'll call Alzheimer's. Alzheimer's is normally highlighted by losing memory short term, losing memory long term. It still has that head forward posture. They tend to be slowing down also, but that process of losing the posterior compartment or adult brain is because we are losing brain. So, but in this process of Alzheimer's, we're not highly emotional. We're frustrated because we know we can't remember things. We know we can't do things like we were. We tend to be losing maybe a little bit of our personality along with it too. But that's the frustration. It's not like frontotemporal demise, which Alzheimer's tends to be more in here. Frontotemporal demise is more in the emotional part of the brain, particularly in the insular cortex area, and has to do a lot more with the emotions. And so these people have no emotional control. They tend to have rapid, highly explosive emotional mood swings, and that is more in this area. The frontal lobe activity loss for Alzheimer's and Parkinson's tends to be in these same areas, but it's highlighted by loss of movement. They tended to be what we call hypomemic, which means their brain was slowing down, their thought processes were slowing down, but so are their movements severely slowing down. And then pretty soon they lose their ability to function the movement system. But it is a non-emotional movement, not a limbic movement system. So we draw this out. Alzheimer's, Parkinson's, and dementia. Non-emotional, and then we're going to go emotional. Okay? So if they're non-emotional, we're putting them in one of those two categories. If they're having trouble initiating movement, which is a problem with the direct loop of the basal ganglia, we're going to put them in the Parkinson's group. If they still have movement and gait capabilities, then they're likely in the Alzheimer's category here. Now we can separate these three with the proteins. I call it cellular mischief. The brain has a lot of spare time because it's not moving much. We're not up and active. And so the cells in the brain are tending to make stuff that are a problem. I call it cellular mischief. They're proteins that the body can't get rid of. And when we have a Parkinson's problem, they're going to be accumulating a protein called synuclear protein. Synuclear protein. And those are the proteins that tend to fill up different aspects of the nervous system, so they tend to lose activity, like digestive function. They wind up also with erectile dysfunction, and then over time their heart quits to function at a high level. They start to get pain, particularly in the left shoulder, because they're referring from the heart, and they don't even know that they're winding up with a heart issue. Well, it's a nervous system, electrical heart problem, because it's filling up with these proteins. Then eventually they'll lose their sense of smell because the olfactory bulbs will fill up with it, and they can't get rid of it. And so those are the things that are a hallmark of that kind of activity. The dementia and Alzheimer's tend to have different proteins or different effects. One has the tau protein, and the other has a propensity towards Lewy bodies. And they tend to be Lewy bodies and tau. Okay, those are the cellular mischief that's involved, and working to try to get rid of those has been shown to be very helpful in in not only clearing it out, but allowing the system to function better, because it becomes cellular debris, cellular garbage that we've got to get rid of for it to function at its highest level. And when I look at things like that, I feel as a clinician that is an immune system issue, because the immune system is about clearing all that out. Why didn't it clear it out? I want to get it out of there. So, but each one of these, Alzheimer's, Parkinson's, and dementia, have their own hallmarks, but they all have the commonality of decrease in function, decrease in motion. And as we're working to improve motion, working to improve movement, it has been proved that they do better. They function more. They function at a higher level. And so getting the patient involved in different kinds of motion, I also recommend highly balance exercises, but within their capability, helping them to grow that, or particularly to regrow their balance system so that they have a higher level of body control, they're able to do more. I'm always asked whenever these categories come up, the degenerative brain disorders, I'm always asked about memory and what would be really helpful for memory. And in this case, we're back to balance. As we're working with memory, there are three major areas that relate to memory. Short-term, long-term, which is the hippocampus, and then working memory is up here in the frontal lobe. Okay? In the frontal lobe, we're dealing with the movement system, the premotor cortex, supplementary motor cortex. This is all about movement, but the supplementary motor is about stabilization during that movement, or trying to limit movement so that we're stable. Supplementary motor area is something that we tend not to engage. Say, I ask the patient, are you moving? Yeah, I walk a lot. I say, yeah, but does the walking force you to have to stabilize? Are you walking on with good, solid, stable shoes on concrete? That's not very difficult. If you're walking in sand or on gravel or walking on rocks where it becomes unstable, that's a completely different system, different issue. We want to ignite not only the movement and all the premotor stuff that goes with movement, we want to ignite stabilizers at a high level. We tend not to do that with patients that have Alzheimer's, dementia, and Parkinson's because we want to avoid injury. And I am not for injury. I am for doing it wisely, and there are ways to do that, and we will teach you how to do that in coming videos. But there are things that you can do that will cause you to have to stabilize. This will get, instead of getting this areas, these areas in here, we're going to get this entire area involved. That's why stabilization is such a big bang for the effort, for the investment. And so doing those kind of activities are going to force the activity level to go higher. This is the working memory. It is equivalent to the RAM on your computer. Random access memory. The bigger the RAM, the more you can do with your computer and the faster you can do it. If you have a high level of RAM, you can run several programs and pull stuff from your memory system easily. With the working memory, we get things, this is the stuff I remember right now, short term, we can get it into the short term, we can get it into the long-term memory. But nobody has a memory problem. They have a memory retrieval problem, and that's the real issue. Can I get it from long-term? Can I get it from short-term back up into working memory? And so building this part of the system is the effect that we need to do in order to radically increase the potential for memory. And so that is my answer relating to that. We also have many things that we do that turn on the brain, turn on the brainstem, get the system to function at a higher level. These things are very strategic. They are where they need to be. If you give a medication, it's only going to work. It's going to work on everything. It goes everywhere. You know that old adage we hear on the TV all the time. It goes. We take this pill and it goes straight to the pain. What a pile of garbage, right? It goes everywhere, and we don't want it to go everywhere. We want to work the areas that need help and leave the other ones alone. And so that's how we do what we do here at Advanced Neurospinal Solutions. If you have any more questions, you're welcome to ask. I'm happy to do more videos. Our YouTube site keeps getting bigger. Plan on having quite a few more, so help us out by asking us questions, and we'll do some more videos. Thanks. Bye.